Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Steven Newmark, Chief Policy Officer at the Global Healthy Living Foundation. Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life. Today, I'm joined by Clayton Ruley, Director of Health Equity and Community Engagement at the Community Liver Alliance, a national nonprofit doing vital work to improve the lives of people affected by liver disease. I met Clayton during a recent week of advocacy in Albany, where we were pushing for more transparency and patient-centered outcomes in the 340B drug discount program, a conversation that gets to the heart of health equity and access in healthcare. Clayton brings over 20 years of experience working at the local level with patients and families, and now leads national efforts to elevate the voice of underserved communities in liver health policy. Clayton, welcome and thank you for being here with us today.
Thank you so much for having me, Stephen. I'm glad to get a chance to speak to you.
Clayton, you've spent more than 2 decades working at a community health clinic serving low-income patients. Can you take us back to some of those early years of your career, and what kind of services did the clinic provide, and what drew you to that work in the first place?
To start off, I come from a family of social workers, mom, dad, brother, godfather, sister-in-law.
Wow.
Helping people, being in the helping people profession, whether it's in hospitals or education or working with senior folks or working in the prison system. And in my case, working with people who use substances, people who are living in poverty, doing sex work, other risky behaviors. These are just things that we did. I would say early on, I started as an intern trying to gain some experience. Well, actually, I started working with children and families when I got out of my undergrad. I was a middle person between human services and parents who might have gotten into a little bit of trouble with the system, and tried to help them get their household together and give them some resources and just be someone that they could be in contact with on a regular basis for a period of time until they get what they need done and we could close out their case. Then I went to grad school and I did an internship. And one of the places that was proposed to me was working at a smaller harm reduction based organization in Philadelphia. And when you work there, it was really about getting the job done. Although you had a title, the title didn't define what your workload would look like because it was about servicing the people. So technically, I ran free medical clinics and I ran our MOUD program, so medication for opiate use disorder, or MAT, medication assisted treatment program. But I also ran a drop-in center, and I also worked with volunteers and interns because when I graduated, I was one of the only people who had MSW and could bring people in for direction and mentorship and supervision. And we were at our lowest, probably down to 2 hands and a couple of fingers worth of people that were there. But the stick-to-itness of the leadership there, including myself, and the need for folks to get the help that they needed, helped us persist through some really dark times and continue to expand services as we got more opportunities, including 340B funding, as you had mentioned earlier, where we could provide more than just our main services, but also services that could really help with the wellness and the livelihood of the people that we worked with and worked for, which is our participants.
First of all, that's fantastic, your background and how close you are to the patients themselves. What have you learned over the years from listening to these patients that you think policymakers and health systems often miss?
I would say one of the main things that I've learned is that people need options. It can't be a one size fit all solution for individuals. I worked with a lot of people who were battling substance use and other risky behaviors. They're not going to necessarily get it when you want to, where you want them to, how you want them to. They need opportunities. They need opportunities to fail. They need opportunities to succeed. I can tell you on all my digits, hands and toes, how many people told me it took them multiple times to get the help that they needed, because you think you're ready and you're not ready. You are ready. There isn't that option for you. You're trying your hardest and then another barrier gets thrown in your way. So I would say with policymakers, options are a really big deal for folks. And I would also say compassion, working with people human resilience is really amazing in a positive way, but also in a way that would surprise you sometimes. Let's say, for instance, you are telling folks that you need them to go into shelter, or you want them to go into shelter, or you want them to go into treatment. If them accessing treatment means that they are dealing with staff people who don't seem to have their best interest in mind, talk to them any way that they want to talk to them, are always threatening or always giving them a hard time, there will be many people who don't feel like it's worth enduring that, even if it means getting the help that they want and the help that they know that their family and friends really want them to get. So there are folks that would rather be on the streets than be in a shelter and feel like they're being talked down to and made to feel like they're less than human because of what they look like, how they smell, who they are as a person. Same thing with treatment, same thing with the hospital systems, same thing with community centers. Any point of outreach that is being offered needs to be offered with care, compassion, and honestly, if you don't want to do the job working with the people, then you shouldn't be working at that institution. But it's not a do it my way or get out that needs to be pushed by these systems that are supposed to help us. It should be, what can we do to help you in a kind and compassionate way? It doesn't mean that you're unrealistic. This is like harm reduction. It doesn't mean that you're unrealistic about what people are doing and how it can be harmful to them. It doesn't mean that you have to treat everyone like they're soft pieces of candy. You can have conversations with individuals, but they have to know that it's coming from love, respect, and general care for them, not just trying to be a bully and push folks around because they're, in your mind, less than they are.
Oh, yeah. Well, tell us a little bit about the Community Liver Alliance, what the organization does, and your role as Director of Health Equity and Community Engagement.
Well, since the time that we talked, my role has actually changed. So let me give you my new title. I'm the Director of Strategic Initiatives, Mission Advancement, and Impact. And this is at the Community Liver Alliance, which is a nonprofit organization that is based in Pittsburgh, but one that has ever-growing national and even international presence. We reached over 40 countries with our services, especially after COVID, as virtual became more of a standard. We do all things liver health related. Obviously, with my background, one of the things that I worked with many times is people who were afflicted with hepatitis, particularly Hep A, B, or C. My tie into the Community Liver Alliance is being able to work in and around the hepatitis sphere, but also learn around new forms, to me, of liver health and liver diseases that might not be brought up in the harm reduction sphere all the time. So we do workshops, we do trainings, we do advocacy, as we talked about, Steven, the ability to go up to Albany, me going to Harrisburg in Pennsylvania. I was just in DC on a chronic disease day, advocacy day, talking to state senators, or US senators and US House of Representative members. So advocacy is a big piece of the work that I do, networking with other organizations that are doing the work. As Susanna Mazardis, our executive director, says, we're stronger together. There's no need to reinvent the wheel. We work with other liver disease organizations or organizations that work in specific liver diseases. If you have the expertise, then we want to be a place that you can come to and get support from, not feel like you're being threatened by. So we work with partner organizations around the state, around the country, increasingly around the globe. We do workshops and trainings for patients, caregivers, medical professionals, like how to treat for hepatitis C, how to diagnose Hep A, for instance, fatty liver disease, other forms of liver health, PBC, focus on pediatric liver health around the hepatitis as well. Basically, all things liver is what we're involved in, and I personally am trying to bring a harm reduction approach to the liver disease space, and I'm trying to bring more awareness around liver disease outside of the hepatitis to the harm reduction space.
Wow, it's great the work that you do. I really love how CLA is really patient first in your mindset and focused on that. We're about halfway through 2025, and it feels like every month brings a new set of challenges. What are the top policy priorities for the Community Liver Alliance this year?
So you spoke about earlier, 340B is a major program, federal program that gives entities, both small, medium, and large, mostly large, the opportunity to save money on prescription drugs by working with pharmacies and being able to get a discount to hopefully work and repair. So the 340B program is one of our major challenges. We have a question both on the federal level, where we think that the decision making should be made first because it's a federal program, but also on the state level on how transparent organizations should be that are receiving 340B funding to ensure that the discounts that they're receiving on the medication, which can lead to you using for other benefits, are going to the communities that need it most. So we're talking about, in particular, rural areas. We're talking about urban areas that oftentimes don't have the same access to healthcare, oftentimes don't have the same rate of access to employment and other affected by other health disparities. The 340B program should be a program that encourages, yes, the savings on the medication, but also the put back in the community to those organizations. And if they're doing it, all we're asking for is transparency and letting their state see that they're doing it. If they're not doing it, obviously we would want to know that too, but you don't know unless you hold people's feet to the fire and be accountable. I don't think that it's an issue mainly with the smaller to middle size agencies, because a lot of those agencies are used to doing the dotting of the I's and the crossing of the T's on a regular basis just to fight. But you have larger entities that I think have many ways of shifting the funding that they're receiving into different pockets. And some of them are in communities, and you see that they're making a lot of money and expanding, but are they expanding in those communities that need it most? So 340B is definitely one of the major programs that we're working on. We've been in several states educating and advocating for 340B transparency and accountability on the state level, and that they allow or ask the federal government to change what's wrong with the program itself. What you don't want to have, especially in this environment federally, is you don't want to have entities getting money hand over fist without any accountability of where that money is going. Is it going to the CEOs? Is it going to upper staff? And meanwhile, the community that they're in doesn't look like it's changed at all. There's different ways that folks can use the 340B money. I mentioned that I worked at a harm reduction agency in Philadelphia for many years, where I'm based out of. That turned into, having an HIV clinic that had 340B money rolling through it allowed us to start a shelter for folks who were that close to getting their permanent housing. It allowed us to, and I'm speaking about Prevention Point Philadelphia, it allowed us to hire more case management so folks can get more access to resources. It allowed us to start doing Hep C treatment, working with organization, a community partner. It allowed us to do street outreach. Basically, we expanded our services, and a good reason for it was because of 340B funding. But that money that we were able to save on getting cheaper medications to folks was put back in the community, even if the community didn't like us because of what we did. We practiced harm reduction, so we did syringe services and we did other safer activities when it came to drugs. And we were keeping at least that nuclear community that we were working with regularly healthier, which meant that the community at large was going to be healthier. You don't want a community running around with more hepatitis C, more HIV, more wound issues, no access to health care, no access to mental health care. So us doing the work that we did was good for the nuclear. And then you had some folks who were living in poverty just in general who accessed our services too. It could have been meals. It could have been a mailing address because they didn't have a place that they can trust for a mailing address. It could have been clothing resources. You name it. We really tried to be accommodating to the community at large, and specifically the folks that we work with. So the 340B program has major opportunity to help organizations doing the work in the community. We just want to make sure that on the state level, there are folks who are receiving the funds are having to report on how it's going back in the community. So that's, long story short, one of the things that we're focusing on right now. I would also say non-medical switching in the state of Pennsylvania is something that we're really focused on. We're happy to say that we do have a co-sponsor memo out right now with Rep. Tariq Khan and Rep. Ann Flood. On the House side, we're working to get reintroduced on the Senate side. But non-medical switching basically is when you are on a health insurance plan, you are on a medication, treatment, or device, you're doing well, and then for non-medical reasons, you are being asked to switch off of that medication, treatment, or device before your plan year is up. It can be very frustrating. It can be very debilitating to the patient and the caregiver to have to switch off of a medication, even if it sounds like it's the same medically. I always say, like, there's like the medical side of it, and then there's like that mental side of it where you're kind of like, oh my God, I just finally got stabilized on this medication. Now, what am I going to do? It can lead to folks not accessing their healthcare provider. It can lead to folks obviously having side effects that were not on the medication that they finally got comfortable on. And we're just asking, the insurance does not switch people off their treatment device or medication for non-medical reasons. If it's something that the FDA has said could be a health concern, obviously we're not saying just keep on giving them something that has been officially diagnosed as a problem medication, treatment, or device. But if you're just trying to save a buck, either for that specific medication, trying to switch out to a generic or switch out to a biosimilar, at least give the grace of allowing that to go away at the end of their plan and allow the person to have the decision making, do I still want to be on this insurance moving forward?
Yeah, no, absolutely. Those are really big priorities for the Global Healthy Living Foundation as well. 340B is something we've been fighting about, and it was great to join you in Albany and continue on, and hopefully we'll have the opportunity to do that again.
What we're seeing with the potential damage to Medicaid and Medicare is going to be huge. We want people to get into care and have easy access to care no matter where they are. The effects of what's happening on the federal level is going to trickle down to state and local levels. So it's going to be really important that states react justly to help folks remain insured so that they can get the care that they need for their liver, their kidney, their heart, their brain, and so forth.
As a reminder to our listeners, the estimates on the Build Back Better bill, which is now law, are that 11.8 million Americans are going to lose access to health care, Medicaid mostly, as a result of the bill. So it doesn't take effect until 2027 after the midterm elections for some reason.
Coincidentally,
right.
I don't feel like it's a coincidence.
Yeah, I was being facetious.
Yeah. So there's some time to prepare. Hopefully there's some time for organization. All the different states can get together, but some of the states are already dealing at a negative deficit. Some of the poorer states in the union are already struggling. So more states being affected without having those same amount of coffers that some of the bigger states, like let's say New York, Pennsylvania, California, will be very challenging to make sure folks stay on insurance. There's going to be a lot of decisions individually that have to be made. If your premiums are going up 50% or whatever the numbers are, there's going to be a lot of folks that are going to decide, I might have to wing it insurance-wise because I can't afford it. And then obviously the folks with chronic diseases that need that assistance, you can imagine the blow it's going to take on their wallets, their ability to pay for their rent. There's not going to be a lot of extra spending money in those households. So it's a really interesting time for sure. It could be debilitating for families, both from the patient to the caregiver to the people around them to the overall community, if this continues in the way that it seems like it's going to.
Oh, absolutely. Absolutely. Well, Clayton, thank you for sharing your insights and for your decades of service on the front lines of health equity. From the clinic to Capitol Hill, your work truly exemplifies what it means to be a health advocate. And to our listeners, if you want to learn more about the Community Liver Alliance or support their advocacy efforts, visit communityliveralliance.org. Thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you found this episode helpful, please leave us a rating or review and share it with someone who cares about healthcare policy. And be sure to follow us wherever you get your podcasts. You can find all of GHLF's podcasts at ghlf.org/listen. I'm Steven Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.